Dilution of blood clotting factors as bleeding continues may make it harder and harder for the bleeding to stop. Fresh frozen plasma can be transfused in patients with an elevated INR from warfarin therapy or liver disease. Furthermore, FFP should be given to correct iatrogenic coagulopathy as well, as transfusion of packed red blood cells and crystalloid doesn't replace clotting factors. FFP is actually a part of massive transfusion protocols. Serum chemistry should be checked in all patients with a suspected GI bleed and can actually be a very useful diagnostic indicator. Blood from upper GI bleeding is metabolized as it transits the GI tract. Some of the urea released is reabsorbed, which elevates the measured BUN. A BUN to creatinine ratio greater than 36 is highly suggestive of an upper GI bleed, and the likelihood just gets bigger as the ratio increases. Reabsorbed urea can't be excreted as efficiently by the kidneys in patients with renal disease, including acute renal injury from hypovolemia. Urea builds up, causing uremia. Uremia may be present in patients with kidney disease and can cause uremic platelet dysfunction. In these cases, dialysis would be nice, but often can't be performed. In a pinch, desmopressin, or DDAVP, can be given to help temporarily improve the uremic platelet function. Very frequently, an NG tube will have been placed, particularly in the case of hematochezia. If a lot of blood is suctioned out, that's a good indication that there's a GI bleed. Side note, if there's just a little blood, it could be from traumatic NG placement or irritation of the esophagus or stomach mucosa from the NG tube. However, the specificity is particularly poor, meaning that if there's not blood, it doesn't effectively rule out a GI bleed. Same goes for an antiquated test called an NG lavage. So antiquated that it belongs in a museum. Like the Melina Brea History Museum. A museum that totally doesn't have any amber. But that doesn't mean you won't still hear about it. With the diagnosis of an acute upper GI bleed in hand, it's time to consider treatment. In all cases of upper GI bleed, proton pump inhibitors should be administered. Most often you'll see this as a continuous infusion, though studies have shown that intermittent IV boluses may be equally effective. PPIs are given because reduction of acid actually helps stabilize clots and stop bleeding, which is useful no matter what the cause. The next step in management depends on the patient's clinical status. You better make sure that one's definitely animatronic before shining a light in there like that. Of course they're all animatronic here. As I've said, we don't have any genetic recreations of these animals. Yet. Luckily, most patients with acute upper GI bleed or bleeding are hemodynamically stable or can be stabilized with IV resuscitation. In these cases, EGD, the gold standard for both diagnosis and treatment of upper GI bleeding, should be performed, preferably within 24 hours of presentation. And that's the second answer for our clinical case. Just a few more things to cover before we're done. If you scope a non-critically ill patient with or without peptic ulcer disease and an acute upper GI bleed, it's reasonable to assume you'll find a bleeding ulcer. With acute erosive gastropathy, however, the findings on EGD are a little different. Here's what we can expect to find when we scope Mr. Jones. Instead of focal ulceration, there tends to be multiple areas of petechial hemorrhage or erosion throughout the stomach. In some cases, especially if endoscopy is delayed, evidence of mucosal regeneration may be the only finding. Most upper GI bleeding can be treated endoscopically, usually with direct thermal coagulation or placement of hemoclips. If damage due to acute gastropathy is more widespread, it can be a little more complicated. More on that soon. Biopsies of any type are contraindicated in cases of active bleeding, even if they're indicated for other reasons. For example, testing for H. pylori. Wait till after the patient stops bleeding. The overwhelming majority of upper GI bleeding can be diagnosed with EGD. But if absolutely nothing is found on EGD, you have to look somewhere, namely the small bowel and lower GI tract. Since lower GI bleeding is much more common than small bowel bleeding, especially if the patient presented with hematochezia, colonoscopy should be performed for cases of GI bleeding where EGD failed to demonstrate a cause. For more on the ins and, well, mostly outs of lower GI bleeding, check out the diverticulosis sketch. If you still come up with nothing after EGD and colonoscopy, the very last place to look is the small bowel. Small bowel bleeding, formerly called obscure GI bleeding, is a pretty uncommon source of upper GI bleeding. Nonetheless, it is possible and should be considered after negative EGD and C-scope. This camera on the suspicious-looking genetic laboratory building is meant only to remind you of our next imaging study. It most certainly is not the highest quality, state-of-the-art security possible for a secret under-the-books genetic lab. Video capsule endoscopy, VCE, in which the patient swallows a little GoPro pill cam, is usually the first line in cases of suspected small bowel bleeding. Small bowel enteroscopy is also gaining some traction, but is highly specialized and only available at large medical centers for the time being. So that kind of finishes up the slower diagnostic trail, followed when patients come in with slower, less hemorrhagic shocky bleeds. But remember, even though patients may have stable vital signs, they can still have severe bleeds requiring multiple repeated transfusions of blood products. However, while it's less common these days, patients may come in with severe hemorrhage refractory to stabilization. If a patient remains unstable despite resuscitation attempts, you can't perform EGD. It's contraindicated for unstable patients. In these cases, patients can go to angiography, which can be both diagnostic and therapeutic, as the interventionalist may be able to locate the bleeding vessel and inject it with vasopressin or a procoagulant coil to stop the bleeding. This can also be performed in cases of severe bleeding when EGD and colonoscopy fail to identify the source of the bleed. But there's still severe bleeding going on. Angiography is quite useful for identifying the bleed in these cases. However, it's important to note that if something is bleeding intermittently, meaning on and off bleeding, even if severe when it is bleeding, angiography performed during a not bleeding time will fail to identify the source. Luckily, surgery for acute upper GI bleeding is relatively rare now due to the advent of PPI therapy and advances in endoscopic therapy. However, in some cases, like massive hemorrhage or recurrent bleeding after treatment with EGD, it may be required. The type of surgery performed for upper GI bleeding is dependent on, not surprisingly, the cause of bleeding. For duodenal ulcer bleeding, which is the most common type of upper GI bleed, gastroduodenal artery ligation with gastric acid-reducing vagotomy is a common surgery that's performed. For gastric ulcer bleeding that's refractory to treatment, distal antrectomy, also with acid-reducing vagotomy, is performed. Finally, acute hemorrhagic erosive gastropathy. Because it's diffuse and because it can cause life-threatening hemorrhage, though rare, some extremely rare cases of acute hemorrhagic erosive gastropathy require subtotal or even total gastrectomy to stop bleeding. Let's sum all this tar up. Upper GI bleeding may be variceal or non-variceal in origin. Variceal bleeding is not covered in this sketch. Upper GI bleeding will present with hematemesis, melena, or hematochezia, or some combination of the three. Hematemesis may either be coffee ground from a slower bleed or bright red blood from a more brisk bleed. Melena is black tarry stool from the digestion of blood as it passes through the GI tract. Typically, melena results from bleeding in the GI tract proximal to the ligament of Treitz. Hematochezia is blood coming out of the anus and is typically associated with lower GI bleeds, but approximately 10% of hematochezia can be from upper GI bleeds. Vital signs may give clues to how severe the bleeding is. Tachycardia is the first sign and indicates 15 to 30% blood volume loss. Orthostatic hypotension may also present and is defined as a fall in systolic blood pressure of 20 millimeters of mercury or more, or a rise in heart rate by 20 bpm or more when changing from supine to sitting or standing. Hypovolemic, aka hemorrhagic, shock develops when there's 30 to 40% blood volume lost, resulting in sustained and sometimes profound hypotension. The most common cause of upper GI bleeding is from peptic ulcer disease. Acute erosive gastropathy is another cause, which can be brought on by decreased perfusion to the gastric mucosa from critical illness, sepsis, or trauma. This also includes Cushing's ulcers and Curling's ulcers from major traumatic brain injury and major burns, respectively. NSAIDs, alcohol, cocaine, and chemotherapy drugs are all associated with erosive gastropathy. Another rare cause of upper GI bleeding is aortoenteric fistula as a complication from previous aortic surgery. Bismuth and iron may mimic GI bleeding by causing dark black stools. These should be ruled out while working up GI bleeds. For management of a patient with upper GI bleeds, they should be made NPO, have 2 large bore IVs placed for resuscitation, labs should be taken including serial CBCs, coagulation labs, and metabolic panels for BUN monitoring. A BUN to creatinine ratio greater than 36 make a GI bleed highly likely as blood is digested and reabsorbed as urea. FFP may be given for coagulopathy due to warfarin therapy,